Hello everyone. I would like to welcome you for this Onco Pathology Conclave 2025. My deep apologies for not being here in person. Unfortunately, at present I'm out of the country. But this is a very important conference, particularly at a crucial time when we are talking about innovations in oncology, precision oncology. How do we do the right thing to the patient the first time? So Triesta Sciences, part of HCG, has organized this meeting to bring expert oncopathologists together for 2 days to have a brainstorming discussion about what is the importance of oncopathology, how are we going to really take it forward, and redefine the role of pathologists. I'm very happy this conference is focusing on various aspects, molecular diagnostics, precision, leading in terms of breast, urogenital and digital pathology, soft tissue, very important aspects of oncology. It will also provide networking opportunities, interactive sessions, and at the end of the conference, I hope you will get good insight into not only the present of oncopathology, but the future. I would like to profusely thank our team, Veena, Dr. Veena, and their entire team for having set up, across HCG, for having set up this meeting. I would like to take a few minutes to discuss about my views on the role of pathologists, why we have placed such importance in HCG for oncopathology, and how do I see that as an integral part of decision making for the patient. As we all know, when we were in medical college, studied, pathology was considered something sitting behind the bench and giving a diagnosis, looking under the microscope and give a diagnosis. And rarely there was clinical interaction with the patient. At that time, of course, we were not deep into the oncopathology. We were not deep into the various markers. We were only scratching the surface of oncology. Over the last few decades, oncology space has expanded by some standards. The therapy changes every 3 months. That is the level of knowledge we are accumulating in oncology. In our tumor boards, I always say the two pillars of oncology are molecular imaging and pathology. That is why, we migrated very quickly to digital pathology, precision pathology, and in our tumor board, we make sure the pathologists are integral part of decision making. I will give you some examples on this and why I feel pathologists are not just pathologists now, they're clinical pathologists. In my view, there is a huge difference when I say clinical pathologists. For example, traditionally it has been that the oncologist orders a test, the surgeon does the biopsy, pathologists give out the report, and then say, okay, I suggest do this other things and leave it at that. They are not actively participating in what happens to the patient. Is the patient got all the markers? Was the decision taken for the patient treatment based on these markers? That level of involvement has not been there in the past. But as we know, HCG is a game changer. We decided to take this on and make pathologists integral part in decision making. So when a patient comes to tumor board, when evaluated, the pathologists, molecular diagnostics, the genomics division, the radiologies, all are there reviewing all aspects of the diagnostics tool we have, suggesting newer ones, markers, what is it we have missed. So one of the most important development in my view has been identifying the exact nature of the disease and predictive analysis of this to say whether the patient has aggressive disease, whether the patient should be treated differently from what is the so-called norm, and what will be the outcome of this patient. So for example, a simple example like TILS. Is this patient having hot tumor, cold tumor? What is the PD-L1? And based on this, can we decide on what should be the right treatment and what is the prognosis of this? What is the microenvironment, which is now becoming more and more important, not only in the diagnosis, but even in terms of what type of therapy we will give. This is a very important part to understand. I do know some pathologists are still wondering whether importance of hot and cold tumor, whether how to classify them, all of this is in discussion. But with the help of our pathology team, Veena, and the whole team, Dr. Veena and the whole team, we have come to a conclusion these are important markers and we have clinical data and evidence to back it up. For example, you take head and neck cancer, I will focus on buccal mucosa or tongue cancer. One of the surprising things for us was majority of them, close to 70% or more, could be hot tumors, could be PD-L1 positive, and possible they will respond effectively to immunotherapy. So a case in point, if such a report is not given for a tongue cancer, let us say it is a T3 lesion, we know the prognosis is very bad. So normally the surgeon or the team which looks at it and say, okay, the report has come as squamous cell carcinoma, well, highly undifferentiated, aggressive tumor, let us go and operate. Then the radiation oncologist will come and say, okay, I'll give radiation with some chemotherapy like cisplatin. Then we always ask, what is the prognosis of this patient? Oh, 40 to 50% chance of recurrence. I always feel when the doctor feels there is a 40-50% or more chance of recurrence, are we doing the right treatment? Because nearly half the patient population are going to recur, maybe even more over 5 years. So there is something fundamentally wrong here. Whatever the NCAN protocol is and all, one as an oncologist, as a well-trained oncologist, you cannot accept. So that is when we go into deeper study of these patients, not when they recur, but very first time. Some of our doctors say, oh, let us do the deeper studies when they recur. What is the point? When they recur, the prognosis itself becomes worse. Isn't our role to prevent recurrence as a team? Or should we wait for recurrence to do all the analysis? Of course, people talk about cost, people talk about issues. But, my dear pathologists, I just want to say one thing. We have trained as doctors. We have spent 5.5 years in medical college to do our MBBS. Then we do a degree, postgraduate. Then we do additional qualification fellowships in oncology. All of this is to do the right thing for the patient. We cannot treat the patient substandard. So here, the role of the pathologist, oncopathologist, is to understand and give the significance of the disease and point out who are likely to benefit from what, who are not likely to benefit, and have an interaction with the clinical doctor. and even include the molecular imaging. What is the SUV of this patient? How does this SUV relate to the pathology? Based on this, what do you think? Is there a body immune mechanism which we can activate to make sure the body itself can take care of this disease, stimulate the cells, T cells, or break the shield so the T cells can essentially go and kill these abnormal cells? That is what the microenvironment is. That is what we should be focusing on. As we all know, I would like to take a complicated situation and simplify. I believe in simplicity in complexity. We all know what is cancer. Relentless growth of abnormal cells. And our goal should be to see how they die. Unfortunately, normal cells die, abnormal cells don't die. Actually, it should be the reverse. If normal cells continue to grow, abnormal cells die, it prolongs our lifespan. But here, whatever words we call senescence and others, normal cells are dying, but interference in apoptosis. So our goal has to be here in a very scientific way to target and understand why these cells are growing and how do we kill them. Historically, we have done chemotherapy, but unfortunately, chemotherapy kills all the cells. Of course, the assumption is fast-growing cells kill faster than normal cells, but various side effects, mutations can happen because of that. New treatments are needed when the cancer recurs. It really complicates. But in the last several years, very few chemotherapy drugs have come in the market because the focus has been on targeted treatments, immunotherapy. So in this regard, I would like to spend few minutes talking about how you all can play an important role in the era of targeted treatments and immunotherapy. When you take immunotherapy, we have to look at, obviously, is the patient going to respond? So the pathologists, the clinical pathologists will help us in identifying hot versus cold tumor. If you say it is a hot TILs, then we look at PDL. Or even a cold tumor, we are doing some study to see how many express PDL1. When you get this data from this, we start bucketing and say, okay, these patients can be treated with immunotherapy alone, maybe immunotherapy with chemotherapy. And now the concept of converting cold tumors to hot tumors, that is where you can be of immense help. For example, I take a patient and give certain drugs, maybe metronomic chemotherapy or certain drugs, traditional drugs, old drugs in a new bottle, and convert this cold tumor to hot tumor. And when we do the repeat biopsy, they may become more immunogenic. At that point, we can intervene with immunotherapy. For example, in this era, we have extensive experience in this treatment, extensive disease in nasopharynx, extensive hot tumors of buccal mucosa. With even low doses of immunotherapy, giving excellent responses. We are actually putting together 100 cases to publish it, showing what a remarkable change this kind of analysis has made for the patient outcome. Short term, they are going into remission remarkably well. Even surgery is showing complete remission, PR, which is again very important for us. And that is the role of the pathologist to tell us, is it a PR or a CR? Obviously, a CR is more important. When there is a complete pathological remission, we believe the patient outcome is better. But for that, we request the pathologists to do minute slicing to see that there is not a single cell of malignancy to say this is a complete CR. When you achieve that, the prognosis will dramatically improve. So it is a complex situation identifying hot from cold tumors. Hot tumors, PD-L1, can be treated with immunotherapy, with or without chemotherapy, majority of the time with. Dramatic response. Once you get the response, you do your surgery, radiation, follow them to see how will be their 2-year, 4-year, 5-year survival. We believe they'll be far better than traditional way of treating all tumors, cold, hot tumors, the same way, where the outcome will be different. For obviously, cold tumors may be more aggressive. Then we isolate cold tumors, treat them with therapy, maybe chemotherapy, convert them to hot tumors, and see whether they could go on drugs like immunotherapy and still get the same outcome. The jury is still out on that. I think various studies globally and our own study, because we are, our rate of head and neck cancer is tremendous, 38% head and neck cancer. So we have enough data to show. The most important thing here is data collection. We have to collect all this data to make sure that we publish in a very curated way. And we could be leaders in management of some of these diseases as we go forward. It's a great opportunity for us to collect data, curate it, publish it in the proper way, and to show to the world what is a very difficult cancer to treat. In future, it could become highly treatable with potential cure. In this regard, as we move forward, I would like to talk about spatial genomics. When you look at integration of pathologists into genomics, we have a division of genomics which will tell us about mutation, which will tell us what is the mutation and why certain drugs may not be working. In HCG, we do 500 sequencing. We are about to launch complete gene sequencing. Not only that, we are about to go into proteomics, proteogenomics, using mass spectroscopy, where we will be able to tell not only the mutation, but the protein content of that mutation. So will that really work? Because not all mutations targeted work because of certain issues like protein content, blockers, pathway blockers. So we will be able to go deep into it and identify even before we deliver the treatment. For example, HER2, Herceptin, nearly 40% may not be responding. Why? There are some blockers, pathway blockers. How do you unblock this pathway so that the treatment like Herceptin will work? So this is the major challenge for us in the era of precision medicine. In this era of precision medicine, I believe heterogeneity of cancer is important to understand. Heterogeneity of cancer. Because you may see what is the VAF, what is the percentage of expressing PD-L1, what is the percentage expressing as HER2, what is the mutation percentage. This, when you kill those expressing that, what happens to the other cells? Are they going to multiply, grow? How do you identify that? In the very beginning itself, what is the heterogeneity? And this is where the spatial genomics will play an important role for us in looking at a digital slide. What is the expression on this slide of mutations? This is a combined work between the genomic division and molecular diagnostics pathology. We have done some case studies. Maybe during the conference, we will be discussing that. Our team will be showing some of those cases to highlight the importance of this new avenue for proper diagnosis the very first time. For nearly 50 years I've been in oncology. If somebody says, Dr. Ajaikumar, are you an expert in oncology? I said, no way. Because as we learn more, be it clinical pathology, oncology, medical, surgical, radiation, as we go deeper, we begin to realize how little we know about this disease, and it is the enigma of cancer. So it is very important we start bucketing when we treat a patient who is supposed to respond but doesn't respond. we need to go into some of these things beforehand itself. So we can identify who is not going to respond. So we need to create buckets. What is the genomic? Do they have, for example, notch, turf? What are the gene mutations which is making them resistant to the treatment? And what is the correlation between that and the pathology? And what does we don't know the answer yet. Is when there are TILs, that means the body is trying to fight. What does the TILs relate to the genomic mutation? Is there a correlation? Using that correlation, can we make predictive analysis in what should be the right treatment for the patient? In this regard, in my own clinic, where our pathology team actively participates along with the molecular imaging, I would like to say that we see cases which are very advanced, which are told that nothing can be done. All these numbers we use, stage, palliative care and all that. We take them on, and majority of the cases, because we go deep into it, who requires double immunotherapy, who requires a different targeted, who requires an unblocker. When we do all that, we are able to turn around and give that relief to the patient. Not a cure, but even a short-term remission is achievable. That is why I want to send one message to all the oncopathologists here. In HCG, we do not have a hospice care. We do not have palliative section. Because cancer for years has been dubbed as disease which is painful, which is untreatable. But I think it is treatable. It is manageable. Suppose a patient has pain because of a tumor sitting on the sciatic nerve. If you give proper treatment to that after identifying the problem, even a patient with extensive disease, could be pain-free. So all these old terminologies, even calling them stage 4, all of this should be thrown out. We need to identify, using the pathological evaluation, molecular diagnostics, genomics, proteomics, where is the disease? Where is the mutation? Where has it spread? And based on this, what is the right treatment? And how do we get first time complete remission? If we achieve that, then of course we go to the stage 2. How do we prevent this cancer from coming back? Do we have to use continued immunotherapy? Do we have to use T-cell therapy, activated T-cell therapy? Do we have to use what kind of vaccination? What are the other ways? Dendritic vaccines? What are the other ways we can treat this minimal disease so it will not become recurrent extensive disease? This is where, when I say future, I believe future is here now. Future is here. For us, this is the time. People talked in the past about, bedside to bench, research. Then they said bench to bedside. Today, bedside to bench and bench to bedside should happen at the same time for that patient, not for some future patients. So, one of the last things I want to say is research is very important. Lot of people use this terminology, we are an academic institution, we are a research institution, we are a cancer caregiver. My friends, today there is nothing like division among them. HCG has showed that we are a cancer caregiver, we may be a private enterprise, but we are heavily into research, heavily into academics, and we actually have a fund for research. Right now we have close to 10 crores and we'll be doing a lot more to see that we encourage basic research, clinical research in all aspects of clinical pathology to molecular diagnosis, genomics, molecular imaging to actual treatment protocols. So any of you who are interested in some of the vibrant research you want to do, please let us know. We'll be happy to look into that and see how we can support. India today lacks research. We have become followers of the West. It could be because of the colonization effect that we always think. People ask me when we come up with new protocols, sir, where is the evidence? Evidence, my friend, I say, is a moving target. What was evidence years ago is not the evidence now. What is evidence now will change. And we should be partnering this change now. We should be the innovators and not wait for evidence to come from West and say, let us initiate this. We should be the first movers, and we have enormous clinical material to do that. So let us take it up seriously and see how we could work as a team. We could create a melting pot whereby we go into data, curate the data, you use AI, computational work. We are already working with Accenture for that. How do we identify mutations? So-called, unknown origin, unknown significance are becoming significant now. Can we take these unknown significant mutations and do the treatment so that we know these are the targets for us? So it is an amazing field. Oncology is a dynamic field. And I believe, unlike in the past, oncopathology is extremely dynamic. And a lot of it can be done through research orientation, which can have clinical implications for our patients, not in the future, but immediate implication. Then there is the theranostics, molecular imaging. When you see a molecular imaging, when you see certain factors, mutations are there, you can actually give molecular therapy, which is theranostics, to get rid of those expressions, to target those. So amazing developments are happening. I am glad today you are all here to attend this important conference. Once again, I thank our HCG team, headed by Dr. Veena, to take this forward, and very innovative to have this conference. And again, my deep apologies, I'm not actively participating in this, but believe me that I am with you here. I want to make sure this is a very successful conclave, and hopefully many more conclaves to come to take this kind of thinking, what you're all doing in the next 2 days, to higher level. I wish you all the best for this important conference. Thank you.